Is this the biochemistry one? Oh, genetic. Oh, your bio's coming. God, I love her to death. All right, here we go. Let's finish this stuff. We'll get you out in a few minutes. We have to get ready for babysitting. I left it kind of here. Okay. Do you remember? I always do that to let you know wherever you're going to be professional. It doesn't necessarily mean doctor, physician, whatever. Understand you have you have certain responsibilities that always, even as individuals. I mean, it's people try to think about that's the kind of thing you get involved. But back to this, the next thing is called epiphyseal plates. Why we know that's a child? You can see if you look closely here. It's a growth plate. You're pointing to the fracture over here. So epiphyseal plate separates from the diaphysis. That's the structural link. Along the epiphyseal plate tends to occur when chromosomes are dying, calcifications. Remember I told you that zone of calcified. I mean, there's nothing special about that. So what happens is there's a whole, you know all about it. In general, they're not a problem. As long as it's just a growth plate and it doesn't extend into the joint, in general, it is pretty satisfactory. This is a classification system you don't have to know. Okay. Called Salter-Harris. I'll just draw it for you. Okay. And they type these into 5 different problems. Generally, if you look at any of these, generically speaking, this is the joint, so this is cartilage here. I use 2. A type 1 is just basically fracturing along the epiphyseal plate line. Most of the time, like imagine with a twisted ankle, somebody twists an ankle, all of a sudden they rock back. And a lot of times, you won't even see the fracture line, you'll just hurt them. So a lot of type 1 fractures are difficult to evaluate radiographically. It's still a fracture, you should treat it as a fracture. And that was the old what we were told. I mean, even if you don't see it, because sometimes the fractures will not show up on x-rays for about 2 weeks. That's why typically the 2-week x-ray, very, very important. 2-month x-ray for healing is very important. 10 to 14 days in fracture healing, that's the amount of time it takes for the macrophages to start to gobble up the debris. You start to see the white blood cells begin to start to lay down, so you begin to see elements of repair, that occlusion. You see repair that appears to be very different. Okay, another one happens where you get a little chunk of the shaft. So imagine if I redid this, it would be like this. You'd have like a little tongue, and then you'd have the end of the bone over here. That was type 2. And again, really would heal. Very nice. I saw a fair amount of type 2s. That's kind of what you're seeing up here. You might get a little this, but still the joint remains intact. Type 1s and type 2s healed, the fancy word we use called uneventfully. It's not a problem. Put them back together, stick them in a cast, immobilize it. Kids, 3 weeks was magic for a lot of growing bones. The hardest thing is keeping them from running around on the cast. The hard part of the next week. This just gets to show you how in medicine and in clinical science we classify. Classify tells you how to treat it. Here are the ones when we started to get them like this. If the fracture line was not just through here, but also through here, once it got in here, let's see, the next bone would be the joint. Once it got into here, trouble. Now you're affecting the joint, and now typically if it was that severe, you would get potential of a growth plate closing with sides growing irregularly. That's a type 3, if it went all the way up in the shaft, type 4. And then type 5 is sort of odd. Type 5 is like a crush injury. It's like everything got sandwiched together. There was so much damage. All of those are ones that have a bad prognosis. A lot of times you just have to let them start to heal, make a determination on what was going to happen, and at that point, do some type of reconstructive procedure. I mean, I didn't do those. Those are pretty sophisticated. sometimes you would basically selectively take one side of the growth plate and intentionally close it so it would match up with the other. You almost have to estimate the amount of growth that was going on. I mean, the little ones, pretty, you get a 10 to 12-year-old. That's probably the ones where we saw that. There'd be some pretty significant accidents. So, like I said, even for the twisting fractures, there's classification. So if you go into a field with orthopedics, it's the kind of stuff we had to remember. When I took my when I got board certified in orthopedics, okay, so almost 40 years ago, it doesn't count. I don't pay my dues to the orthopedic board, so I can't be a knowledge bank. You have to know all those things. That's the kind of stuff when you go with doctors or people at high level go for certifications. That's the kind of content you have to be familiar with. By that time, we had 3 kids. When the kids went to bed at by the time we finally got everybody to sleep at 9 o'clock, and thankfully my daughter slept the night, I'd be up for 2.5 hours reviewing stuff. Doing what I always did, chain smoking cigarettes. Terrible. This is a depressed. They do not look like that. No one encountered a golf ball. Even if Scotty or Rory hit it right at their head, it's not going to happen. A projectile would have gone through it. So effectively, this is what happens. What they call it depressed skull fracture. It breaks enough, but it's the force. Even though that may or may that one did break, but you can imagine the kind of damage it does inside. Your skull is remarkably strong vis-a-vis trauma. Remarkably. So I mean, it's pretty hard. Skull fractures are not. I mean, you don't see it without again head protection in sport. It's funny because Dr. Buxton and I are big soccer fanatics. We see it in soccer again. They've had a couple of very, very good, elite, we're talking about, players winning at the highest level, getting, having fractured skulls that were there. So, I mean, that's one. So that's why when the depressed skull fracture and that construction is so important. And now the difference between this is, they're calling this a green stick. I can agree because you can see the growth plate. You see a growth plate. We know, and that's what happens in growing bone, and the fracture is incomplete. What we will often see is it will bend significantly. So even though it doesn't appear to be a lot, the bone is such that it's growing, it is unlikely to break through and through. And a lot of times we'll see green sticks with big bends. And really one of the treatments, which surprises people, is you literally sedate the young person and complete the fracture. It actually heals better. I mean, in an adult, assuming that there was no growth plate, that'd be an incomplete fracture, and you wouldn't treat that a cast would be just fine. So it's interesting how those things are. And again, the analogy of the green stick fracture. So that's just a potpourri of things. A lot of the fractures have names that are associated with them. Classically, finding out. I mean, my sports nuttery. When you hear all of these things, when somebody tells me things like that, and we'll actually talk about it a little bit in the lab on Monday, when I start looking at the bones and what defines a high ankle sprain between a regular ankle sprain, all of those kinds of things. We talked a little bit about shoulder separations. Now you're going to see where the dislocation is, the anatomical basis, and we do that in joints as well. And so most of the time, the big distinction is open and closed. If it is closed fracture, you have all of these things you can do. Again, if you have an open fracture, your first concern has to be infection. Your first concern is the severity of it. Is the tissue viable? Is it going to heal? And in the old days, you would intentionally leave the wounds open because if you didn't want to close it and have infection, immediately that bone is infected because of exposure to air. So it limits your opportunities. So if someone comes in, grandma ends up fracturing a hip and falls, are putting in a big piece of hardware, at least we have the option of doing it because inevitably the skin doesn't break. That's a closed fracture. So we can do what's called an open reduction. Reduction means to reduce the deformity. And so we'll go in, sometimes you'll reduce the deformity, sometimes you'll have to remove fractured bone and put it in some kind of prosthesis, something that resembles the bone. But let's say it's just a closed fracture where the bones are broken in a couple of places. You go in there and do the hardware. That's called an open reduction, and the name is internal fixation. So because you're not worried about it, you're worried about infection with a surgery procedure, but you wouldn't do that right away with an open fracture. You inevitably, with an open fracture, you would have to probably wait 7 to 10 days before you would attempt to implant. You would hate to put internal hardware on something that you're not sure if it's going to get infected or not. Unless it has changed, the approach has changed dramatically. I do not think it is. So we used to do, and obviously nowadays there's so many different ways that you can splint removable casts. They were in their infancy. We just casted everybody. When I started putting on cast, plaster. Basically the traditional plaster of Paris cast. That was in the beginning. By the time I got into the office, we started to do fiberglass casting. And I use that in the office all the time. I prefer that. So I mean, it's how I learned it, by the ropes doing that. It was so bad. Gives you an idea of what it's like to be a resident. Being a resident, it's like being the rookie and carrying the pads, the football team. It's that I suffered, so you suffered. We couldn't wear gloves when we put casts on. We would put an orthopedic clinic on. On a Wednesday morning, there'd be 4 of us, 1 attending and 4 of us attending the clinic. Ready? Each of us put on 15 to 20 casts in the morning. We cut them all off on Tuesday and X-ray and recast them on Wednesday after that. Your hands, it's like you had white plaster all over your hands. No gloves. You have to feel what it's like to have the cast on. So all that type of stuff. Traction was used a lot. Traction was designed basically to keep people in bed. But when I told you about those femur fractures in that emergency room, it was putting a pin in there, but effectively the bone was just dressed and they were waiting for infection. Most of these people were in intensive care. Here's how it gets better. Bone heals beautifully because bone has really good. I have never seen so many texts in my life. So the repair involves 4 things. As soon as something is broken, it starts to heal. Cells are disrupted, they release chemicals. Whether you sprained your ankle, whether you had a true broken bone, whether you had a little cut, as soon as tissue is damaged, chemicals are released. They have a fancy name, they're called cytokines. And they summon white blood cells and healing factors to the bone. What happens in bone has a rich blood supply. And so those factors already within the blood are pulled there. And it causes the blood to accumulate. And as it begins to accumulate, typically being held within that periosteum. Okay, that's sort of a almost a girdle around the bone. What happens is it begins to form a hematoma. The suffix "oma" is people loosely talk about it as a tumor. It's really not. It's just a large accumulation. When we talk about tumors, now it's accumulation of cells. So in this case, the hematoma forms this big thing of blood. It hurts. It's pushing against that periosteum, lifting it off the bone. It hurts. That's where it's in the early days where that hurts. At that point, the healing factors for the first roughly 3 days, the hematoma forms and you're in an inflammatory phase. That's when it's fairly sore. Roughly around that, from that 3 days for roughly 3 to 6 weeks, it forms at first a fibrous callus, fibers invade, and then remember, fibroblasts, chondroblasts, osteoblasts. First it's fibers, then it's cartilage, then it eventually becomes bone. So usually sometime, and depending on the bone it is and the extent of the fracture, in those first 3 days, typically 3 weeks is fibrocartilaginous, and maybe another 3 to 6 weeks is bone. And then finally the bone over the next, and this PowerPoint sequence talks about 2 months. It could be a year. Bone takes a long time to do. And someone young and healthy like you guys are, if you fell, broke your forearm, radius or ulna, I mean, assuming it was just a straightforward fracture and healed uneventfully, you wouldn't even know where the fracture was a year ago. You would completely remodel. I mean, short of opening it up surgically and saying, oh, there's evidence of an old fracture here, you would not typically see that. It amuses me when I see forensic shows. Well, it looks like they had an old fracture. Well, if they had a piece of hardware in there, I could buy that. But normally, it's not so easy to tell. But it makes for good TV. My wife hates me. I'm addicted to British crime shows. I love it. And then eventually remodel. So hematoma, torn vessels, massive blood, swollen, painful, inflamed. Worst to begin with, it kind of peaks and calms down by the end of 3 days. While I here, notice that gray represents periosteum. So is that fluid is what's really creating the pain, is it pulling it ever so little off the bone. Then capillaries grow in. Again, the hematoma is filled with blood, but new blood supply comes in. White blood cells clear the debris. That's why you can begin to see the full extent of the fracture. And now collagen starts, then fibroblasts, which can become chondroblasts and eventually osteoblasts. Matrix starts with spongy bone. I mean, so you're going to see it starts with spongy bone as the remodeling completes over time. Now you have the exterior becoming cortical bone and the cancellous or spongy bone in the middle. But in the early phase, it's fibrocartilaginous callus. You can see it here, little bits of blood vessels going in, soft, not so soft. Really, the way we tell clinically, we'll see this, we'll see little flecks, maybe of calcification going on, but if you try to move it, it's very painful. And actually, you can sense that it's moving a little bit. It's not solid. What's the secret to removing the cast or getting them out of the brace? This begins to solidify. It may not be uniform bone. The name we give it is consolidation, and the watchword is solid. So typically, broken leg, 6 to 8 weeks, 4 to 6 here. I mean, you know these things. If it's not doing that, potentially it's a problem. So that's the next stage, the bony callus. We start to see these flecks of bone early, but this converted to bony callus, a spongy bone, it does, I would think it's fair to say that the 2-month x-ray is very important. That gives you a good idea if it is healed sufficiently. It still might hurt. But normally by 2 months, other than something very unusual, probably have healed. So it gives you a good idea. If it's not healing, then we start getting into bad things that are that people who do bone orthopedics and people who do orthopedic procedures like I did, things like what we call malunion and non-union. Ooh, those are very bad because bone's supposed to heal. And then you get very unhappy patients. So here, this would be solid. This would be consolidated bone. There's substantially more bone. You can see it radiographically, etc. And then after this, it's all remodeling. And eventually, it's just the compact bone is laid down, blah, 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 responding to stress. And I mean, will you see some irregularities if you took an x-ray 2 months later? Sure. But I said, off and on, the part that we look for is union. So if this is consolidation, union to me probably could be as little as 2 months, but might take a year. And that's for sure. So it's very interesting. We saw so many fractures. Unbelievable. Which brings us to the last little bit of this. Oh, so good. These are bone disorders. Really the big player is osteoporosis. When we finish with this, you're out the door. Unless you want to stick around and just occupy your seat. Nobody here is. I sense my humor is going unappreciated today. My wife would say lack thereof. It doesn't matter. She could do something wrong. Okay. Effectively, bone deposit versus bone resorption is the underlying thing. A lot of these they classically go under the blanket called metabolic bone diseases. A lot of times, if it's not something that falls into one of these categories, okay, then you start looking for other causes of these. Uh, I mean, and it's more almost in the realm of the endocrinologist. A lot of these, but this is where it goes. So there, Malaysia means softened. So osteomalacia means soft bone. Osteomalacia and rickets are the same thing. The difference is rickets is in children, osteomalacia is in adults. Osteoporosis is a loss of bone, both organic and inorganic. The error people have made for years, oh, it's osteoporosis, you don't have enough calcium. It's more than just that. It's not all about inorganic material. And the oddball, and it's not relatively uncommon, is called Paget's disease. Paget's disease of bone. Now, I'll tell you the reason I'm saying that. Paget's disease, when it's associated with bone, it really has little islands of where there's too much, and island. It's almost like islands of excessive bone and insufficient bone. It's a very odd condition. Do not get it when you see the term Paget's disease. There's maybe the same doctor's name. It's associated with a very interesting, and I wouldn't say rare, but not common form of breast cancer. It's called Paget's disease of the nipple. It's what we call a cancer that's usually in situ confined. So usually there's an irregularity in the nipple that is biopsied, and then if it shows that it's just confined to that area as it spread, that's called in situ. It's where it started. My mom had that, by the way. You know, my mom was just so frightened when she had this done. The procedure she went to this world famous breast surgeon lady because she's very uncomfortable with men. My mom was from that age, very uncomfortable with men doctors when it had to do with lady type problems. She was born in 1918. Give her a break. So here, vitamin D is this. Vitamin D and dietary calcium, which go hand in hand. As you'll remember, you can't absorb the calcium without vitamin D. If you don't have the calcium, who cares about the vitamin D? Malaysia, poorly mineralized, osteoids produced, not adequately deposited, soft, weak bones. We don't see it a lot. The principal cause for this forever has been vitamin D deficiencies, more than there was calcium. We solved this. Rickets was in children, both legs and bone deformities. The ends are enlarged and abnormally long. The bone, I maybe don't have the X-ray. That's this. You have a long bone, tibia, typically the top of the tibia. Some of the flat lines are a real peak. The growth plate would be here, and you start to see it. In rickets, it's almost like this. It's almost like getting no definition. It's like a wall of osteoid. It could be in a trumpet connected at the point, like a trumpet that you would play, like in the band. So it's very distinctive. It's the reason why we have, if you get milk, what does it say? Vitamin D enriched. They started putting the vitamin D to prevent this. It's the same thing with iodized salt. Prevent goiters and having iodine deficiency. So certain additives in the food supply were done for this reason. And so you rarely see this in a modern nation. I don't have any exposure. I've been out of the country, other than to Canada a few times, to Mexico once, and that was in February for my daughter's wedding. Other than that, I am not a world traveler. Oh, we were in England, Scotland. Played golf at the old course. How's that? Nevertheless, to be familiar with that a little bit that's there. So the distinction is whether it's adults or children. Osteoporosis is a whole group of diseases, and it's well stated, where there's more bone being resorbed and not enough deposit. Could it be overactive osteoclasts? Usually is. Is there a reason behind that? It's not necessarily clear. Is there inadequate vitamin D part of the process? Is there inadequate sunlight which activates vitamin D? Does calcium play? Why do we see it more in women? Because we know that estrogen and progesterone, so post-menopausal women, are particularly at risk, and depending on if they have certain risk factors. My first wife, part of the reason we couldn't have kids biologically, she had polycystic ovary disease. It was a long shot she was ever going to be able to conceive. She, when we met and were married, 5 feet and a half an inch tall. She was already very short. She had her complexion was more Mediterranean with regard rather than say Nordic in pigmentation. She was a little darker. That predisposed her. Her size predisposed her. The fact that her ovaries effectively stopped working, she became effectively total ovarian dysfunction when she was about 35. At that point, started on estrogen and progesterone supplements. But that's when they were formulating, so they were like chewables for long-term dissolving under the tongue. We had to go to a couple of pharmacies to do that. She's endlessly out in the sun, loved to garden, like that. Tried to exercise as much as possible. It's just not a winning hand. All those risk factors, no matter what you do, and taking all the supplements and knowing all that stuff. I mean, right now she's probably 4'10". Now she's had, God bless her, she's not had very good health. She's not very good health. And for you young folks, when you get a little older and you've gone through a divorce, you have children and grandchildren, a great grandchild, you kind of learn you got to get along. We get along pretty well. I would say we would have been much better as friends than as husband and wife. It only took us 33 years. So here's the areas. So we see it. Think of the moment of force. That's why hip fractures. Okay. Compression fractures, you saw the vertebrae. I've never seen a better slide to depict osteoporosis. It's moth-eaten bone. Whatever you want to say, ground glass appearance, however you want to describe it. You don't see this on an x-ray until the bone is already about 3/4 gone. That's the problem. Our bodies are like that. We have so many things that as long as we have 25% of the amount of calcium we need, our bones still are pretty good. And then all of a sudden, boom, there's a stretch fracture. There's a compression fracture. There's no magic. You could have had an incidental x-ray to look at the bone and say, oh, that looks okay. Not realizing all of a sudden it's going to go. Aged postmenopausal women. 30% of women age 60 to 70, 70% by age 80. I'm sorry, everybody. You're going to contend with this. Estrogen. So levels drop at menopause, higher risk. Men are less prone because there's more. Women produce testosterone-like substances in one place in the adrenal cortex. We'll learn about that in physiology. Not a winning hand. So insufficient exercise, diet, calcium, protein, smoking, genetics, hormone-related conditions, diabetes, certain meds predispose you to it. Alcohol certainly does. So, my first wife was very aware of all these. We never were drinkers. Still, I'm not. She's still not. Sorry, my eldest was at the Navy War College. This leaving today. We're talking last week. He goes, I'm going to watch the game, so I don't have to worry about being the alcohol. We're going down for bourbon and cigars, Dad. So what's going to do? All those things. Traditional treatments, exercise, vitamin D, bone-sparing drugs, okay? Typically, we think the underlying thing is the osteoclasts become activated by a variety of these factors. So one of the things that they use a lot of are called bisphosphonates. Calcium and phosphate kind of go in opposite directions. So basically, you're trying to, I, I think you're trying to reach, I have to look it up. I will. They either are pulling phosphate in, hoping the calcium comes along, or pushing the phosphates out. They were a monthly shot when they came out. Very hard to tolerate. They had a lot of, like media people and Hollywood people, like they do a lot promoting these things. I'll try to get you the idea what, but he was, I have to get the mechanism. Here's the progenic bone, spongy to compact, high, more spongy, reduced mineralization, certainly in middle age or over. Whenever you see possibly, that's code for we don't know. And again, calcium, these are the bisphosphonates. And I'll find out how they work. So you see areas where here's no, here you can see it isn't there. Here it's very dense, very odd disease. We shall leave it. We will start. Since the bone part is out of it, we'll finish the bones. In lecture, we will start joints on Monday. And that'll dovetail nicely into what we're doing in the lab. And we'll have the bones out for open lab. They're open now because Dr. Robbins is giving a thing.